We begin our comprehensive exploration of dermatological health for those over the age of 60 by first acknowledging that the skin you inhabit today is fundamentally different from the organ you possessed in your middle years, necessitating a radical shift in how we approach the concept of moisturization, not merely as a cosmetic preference, but as a medical necessity for preserving structural integrity. To understand why standard moisturizing routines fail the aging demographic, we must look beneath the surface at the microscopic deterioration of the stratum corneum and the physiological decline in sebaceous gland activity that defines cutaneous aging. When we speak of dry skin in the geriatric population, we are not discussing a temporary state of dehydration caused by environmental factors, but rather a chronic intrinsic condition known as xerosis cutis, which stems from a breakdown in the skin's barrier function. The primary mechanism driving this dryness is the reduction of intercellular lipids, specifically ceramides, cholesterol, and free fatty acids, which act as the essential mortar holding the skin cells together. Imagine a brick wall where the mortar has crumbled away. No matter how much water you throw at the wall, it will simply leak out because the structural seal is compromised. Similarly, after the age of 60, the natural production of these lipids drops precipitously, leading to a dramatic increase in transepidermal water loss, or TEWL, a process where vital moisture evaporates from the deep layers of the dermis through the compromised epidermis and into the atmosphere. Therefore, the first and perhaps most critical advice for moisturizing aging skin is not simply to apply hydration, but to actively repair this lipid barrier using products that mimic the skin's natural biology. This brings us to the scientific imperative of selecting moisturizers that are chemically congruent with the skin's natural composition, specifically those containing a physiological ratio of ceramides, cholesterol, and fatty acids. The science of aging skin reveals that the enzyme activity required to process these lipids in the epidermis becomes sluggish with age, meaning the skin loses its ability to self-repair after cleansing or environmental exposure. Consequently, the application of a moisturizer must be viewed as an external replacement therapy for what the body can no longer manufacture in sufficient quantities. When a patient over 60 applies a generic lotion that lacks these specific lipid precursors, they are merely providing a temporary sensation of smoothness without addressing the underlying structural deficit. To truly treat the dryness associated with aging, one must utilize topical formulations that function as barrier repair agents. These formulations penetrate the spaces between the corneocytes, the dead skin cells that form the outer layer, and essentially rebuild the protective matrix that prevents water loss. It is crucial to understand that this is not about adding water to the skin, but rather about sealing the exits through which water escapes. The most effective strategy involves the consistent application of lipid-rich emollients that settle into the microscopic fissures of the aging epidermis, providing a surrogate barrier that mimics the function of the healthy skin you had in your youth. Furthermore, we must address the widespread misconception regarding the texture of moisturizing products suitable for this demographic, as there is a direct correlation between the viscosity of a product and its efficacy for geriatric skin. The aging process involves a significant thinning of the epidermis and a flattening of the dermo-epidermal junction, which reduces the surface area for nutrient exchange and weakens the skin's resilience. Light lotions with high water content often evaporate too quickly to provide lasting benefit for this thinned tissue. The scientific consensus for skin past the age of 60 advocates for the use of creams and ointments over lotions, as these heavier formulations contain a higher concentration of oil phase ingredients, which are essential for reinforcing the depleted lipid bilayer. This distinction is vital because the aging skin environment is naturally devoid of sebum. The sebaceous glands, while still present, become largely inactive or sluggish, depriving the skin of its natural oil film. Therefore, the goal of the first pillar of moisturization is to create an artificial hydrolipidic film that remains on the surface for an extended period, allowing the reparative ingredients to integrate into the stratum corneum. In addition to the lipid deficiency, we must consider the pH of the aging skin surface, which tends to drift from a healthy acidic state towards a more neutral or alkaline level, a phenomenon that further impairs barrier function and increases susceptibility to bacterial colonization. A compromised acid mantle disables the enzymes responsible for generating ceramides, creating a vicious cycle of dryness and damage. Therefore, the first commandment of moisturizing after 60 is inextricably linked to maintaining an acidic environment. By prioritizing barrier repair through lipid replacement and creating a protective shield that compensates for the lack of sebum, we lay the necessary foundation for all other skincare interventions. Without this structural integrity, any subsequent attempts to hydrate the skin will be futile. Building upon the foundation of barrier repair, we must now distinguish between two often confused physiological needs of aging skin: hydration, which refers to the water content within the cells, and moisturization, which refers to the ability to retain that water. The aging dermis suffers from a depletion of hyaluronic acid, a naturally occurring glycosaminoglycan that acts as a moisture sponge. Therefore, the second imperative for aging skincare is the introduction of powerful humectants like glycerin and urea that can attract water from the deeper layers of the dermis. However, in the context of aging skin, the use of humectants requires a nuanced understanding of environmental physics. If the air is dry and the skin barrier is weak, humectants can theoretically pull water from the deep skin layers and allow it to evaporate, exacerbating dryness, which is why they must never be used in isolation. This potential for humectant-induced dehydration necessitates the third critical piece of advice, which is the mandatory coupling of hydration with occlusion. In the specific context of geriatric dermatology, where the natural sebum production is virtually non-existent, the role of occlusive agents becomes paramount and non-negotiable. Occlusives are ingredients that form a hydrophobic physical barrier over the stratum corneum to physically block the evaporation of water. For skin past the age of 60, the most chemically inert and effective occlusive remains petrolatum, alongside dimethicone and various mineral oils, despite the unjust stigma they sometimes carry in popular media. The advice here is to adopt a sandwich method of application, where a lighter, water-rich humectant layer is immediately followed by a heavier, occlusive layer. This layering technique mimics the complex function of youthful skin, where the water content is naturally high and the oil barrier is naturally intact. By artificially reconstructing this dual system, we ensure that the water drawn into the skin by glycerin or hyaluronic acid is trapped effectively, allowing for prolonged hydration that lasts throughout the day or night. We must also delve deeper into the specific selection of humectants for the aging demographic, specifically focusing on urea and its dual function as both a hydrator and a keratolytic agent. Urea is a unique molecule that at lower concentrations binds water to the skin with exceptional efficiency, but also acts to gently dissolve the intercellular glue holding dead skin cells together, promoting a smoother surface without the abrasion of physical scrubs which can be damaging to fragile, thin skin. Furthermore, it is essential to discuss the chemical sensitivity that develops with age, as the thinning of the stratum corneum makes the skin more permeable to irritants. Fragrances, essential oils, and volatile alcohols can trigger contact dermatitis and chronic inflammation in compromised aging skin. Therefore, the advice to use humectants and occlusives comes with the strict caveat that these ingredients must be delivered in bland, fragrance-free formulations. Having established the biological necessity of lipid repair and the chemical mechanics of hydration and occlusion, we arrive at the fourth and final critical advice, which concerns the methodology and timing of application. The stratum corneum behaves somewhat like a sponge. A dry, hardened sponge is resistant to absorption and requires time to soften, whereas a damp sponge absorbs liquid instantly. For individuals over 60, the window of opportunity for effective moisturization is the immediate 3 minutes following bathing or washing. Beyond the immediate mechanics of topical application, we must broaden our scope to the environmental and systemic factors. A crucial component of our moisturizing strategy involves environmental modification, specifically the use of humidifiers in the bedroom to maintain an ambient humidity level of 40 to 60%. Additionally, internal hydration and nutrition, particularly omega-3 fatty acids, play a supportive role. We are essentially attacking the problem of dryness from both the outside in and from the inside out. In conclusion, the management of skin health after the age of 60 requires a paradigm shift from cosmetic enhancement to structural preservation and repair. The 4 pillars of advice we have explored, restoring the lipid barrier, utilizing humectants, sealing with occlusives, and adhering to strict timing form a scientifically robust protocol. By adopting these rigorous, evidence-based strategies, one can mitigate the inevitable effects of senescence, relieving the discomfort of chronic dryness and restoring a measure of resilience and vitality to the skin.